Hello, my name is Kayla Nelson. I am a registered nurse and a certified hospice and palliative care nurse. Hospice and palliative care are my passions. They are the reason I got into home care so that I could provide a better home care experience for clients at end of life and on hospice services. Not all clients who pass away at home will be on hospice. I think that's unfortunate. I think everyone should experience the beauty that is hospice. Now, what you're going to see in this presentation today is largely based on my education, a lot of it from my experiences. Not all hospice nurses are going to see this the same, not all families are the same, and not all clients are the same. So take the parts of it that you like, and if there's parts of it that you disagree with, explore those more, maybe get a second opinion. But overall, I think this is a really good intro to hospice, especially if you've been a little bit nervous about taking care of a client at end of life. It is my goal today to help you feel more confident and comfortable taking care of someone in their final days, and I hope to achieve that goal by tackling these objectives: defining hospice and palliative care, getting to know the hospice philosophy and the hospice team, learning about who pays for hospice, how you qualify, what are some common hospice diagnoses, and then reviewing pain and anxiety management methods, and then finally we're going to review the death and dying process, the final days, and the final hours. By the end of this presentation today, I think you'll feel more comfortable and more confident taking care of clients for end of life. Hospice care is a palliative approach to end of life that centers around the client and their quality of life. Rather than cure the disease, hospice provides clients the ability to treat their symptoms and manage their pain. Choosing hospice doesn't mean that our clients or their families are giving up. Choosing hospice means that they are focusing on comfort instead of a cure so that a better quality of life can be maintained for as long as possible. Hospice care is personalized to meet the needs of each client. Clients will have an interdisciplinary team which manages their pain and symptoms and designs a plan of care to meet their unique circumstances. An interdisciplinary team will meet the needs of mind, body, and spirit. Imagine raising your hand if you have heard of any of these myths or misconceptions about hospice. A lot of those are things that I heard, and maybe some things that I may have believed prior to working in hospice care. How do you think these myths and misconceptions do harm? Well, many people will not get the full benefit of hospice services because they are held back by the fear behind these myths. And if they knew the truth of what hospice is, they would have a more peaceful death experience. So how do we overcome these misconceptions? Through education and advocacy. By hospice nurses like me, educating clients, families, and caregivers like yourselves, you can then in turn educate and advocate for clients in a better way. The interdisciplinary team for a hospice client consists of a primary care physician and a medical director. Those two physicians are working together to make sure not only does the client qualify for hospice, but the goal is that those two physicians will work together in addressing those clients' needs. There is also a registered nurse and oftentimes a licensed practical nurse, hospice aides, social workers, chaplains who can provide spiritual care, dietitians, volunteers, and some companies even offer holistic services such as massage or music therapy. One important thing to note is that no member of the interdisciplinary team is more important than another. It is so vital that all of these members work together to accomplish the goals that that client may have set. It might sound a little ironic to think about a client at end of life setting goals, but setting goals towards what you want your death to look like, what you want your final days to look like, is vital in ensuring that the client and the family have a positive experience. Hospice care is personalized care, individualized to meet clients' needs. Every hospice client will have access to a registered nurse, a hospice aide, a social worker, a spiritual counselor, bereavement coordinator, dietitian, volunteers, and often holistic services. The number of visits from each discipline will vary depending on the needs and preferences outlined in the client's plan of care. and the frequency of visits are reviewed bi-weekly at interdisciplinary team meetings, and that will change or evolve over time. Not all companies have the same frequencies, so I just kind of picked what I've seen as a hospice nurse and when I worked in a facility, seeing how often some of the hospice companies came in. But at the end of the day, what you want to get from this is that it's off of the client's needs. So if your client doesn't need a hospice nurse to come in 3 times a week and they are doing fine with 1 visit a week, that's okay. But if you notice that your client's not doing well, that there's a change, there's not a maximum number of visits they can have that week. So pick up the phone, call the hospice nurse, let them know what's going on. And if it's a good hospice nurse, which most of the hospice nurses I've worked with or have had relationships with, they're great hospice nurses. They're going to want to come out. They're going to want to find out what's going on, and they're going to want to make sure that that client is taken care of. Hospice is covered for eligible clients under the Medicare hospice benefit, most state Medicaid plans, and private insurance plans. Some hospice companies will provide care regardless of a client's financial resources or ability to pay. Everyone deserves to prepare for end of life and beyond with respect, dignity, quality, comfort, and compassion. There are 2 90-day periods of care, which total 6 months, which are followed by an unlimited number of 60-day periods, as long as the client continues to qualify for hospice. I've seen clients on hospice services for as long as 2 years, but that's not common. Typically, someone who qualifies for hospice has a diagnosis or a prognosis of less than 6 months. That doesn't mean that you have to pass away in 6 months to get hospice services, but it's also not a realistic expectation that someone signing up for hospice will live another 2 years. That's pretty rare. Hospice care is available to clients of all ages, from infants to the elderly. Different hospice companies might only take certain ages of clients. Several factors determine hospice care eligibility. The client's physician and the hospice medical director agree that the client's disease process is at its final stage, meaning if the disease progresses normally, the client's life expectancy is 6 months or less. The client and their family choose to change the focus of their treatment from trying to cure the disease to managing symptoms and pain. At times, the disease does not progress normally, and a client will be provided hospice care services longer than 6 months. It is also possible for a client to graduate hospice care. The terminal illness could cease to show a decline, resulting in an improvement of the client's condition, and the client no longer being appropriate for hospice services. Here is a list of the most common hospice diagnoses for adults and children. This is not an exhaustive list, just the most common. And it is likely that if you take care of a client on hospice, one of these diagnoses are going to be the reason they are on hospice. ALS, or Amyotrophic Lateral Sclerosis, is a progressive neurodegenerative disease that affects nerve cells in the brain and the spinal cord. ALS usually strikes people between the ages of 40 and 70, and it is estimated that there are more than 20,000 Americans who have the disease at any given time. For unknown reasons, military veterans are approximately twice as likely to be diagnosed with the disease as the general public. Dementia is an umbrella term for a decline in mental ability severe enough to interfere with daily life. Memory loss is an example. Alzheimer's is the most common type of dementia. Dementia is not a specific disease. It's an overall term that describes a group of symptoms associated with a decline in memory or other thinking skills severe enough to reduce a person's ability to perform everyday activities. Alzheimer's disease accounts for 60 to 80% of cases. Vascular dementia, which occurs after a stroke, is the second most common dementia type. There are many conditions that can cause symptoms of dementia, including some that are reversible, such as thyroid problems and vitamin deficiencies. Alzheimer's, dementia, or senile degeneration of the brain are diagnoses that hospice clients will commonly have these symptoms, including difficulty swallowing, incontinence, inability to do their own activities of daily living, progressive weight loss, chronic infection, or an inability to maintain calorie intake, frequent hospitalizations, frequent falls, sleeping more, not wanting to get out of bed, and a loss of trunk control. If you have a client who is not on hospice services, has a diagnosis of Alzheimer's or dementia, and is suffering from decline, that you're noticing these changes, you're noticing some of these symptoms, it might be appropriate for you to talk to your supervisor, or if you have a good relationship with the family, it might be appropriate for you to talk to the family about looking into hospice services. It can be a difficult conversation to have, but the sooner you're admitted to hospice services, the more benefits you can get from the hospice period. If you get on with hospice early, you're going to get a lot more care than if you wait until the very end. Congestive heart failure has several causes, including heart attacks, infections, cardiac arrhythmias, high blood pressure, and even genetics. The heart is a pump. Its job is to pump old non-oxygenated blood from the body to the lungs so it can be oxygenated and then be pumped out so that each cell can be supplied. Congestive heart failure is the inability of the left side of the heart to pump an adequate amount of blood due to different factors. Because of this condition, the heart is weak and unable to pump all its blood forward, and sometimes it backs up into the lungs. Heart failure, if left untreated, can cause damage to other important organs. Each and every tissue in your body requires a supply of oxygen and nutrients to do well. Your kidney, liver, abdominal organs, and lungs must be supplied constantly with an adequate supply of oxygenated blood. If your heart is unable to deliver that oxygen-rich blood, those vital organs will fail over time. Common symptoms of congestive heart failure include severe fatigue, shortness of breath at rest, chronic fluid buildup in the chest and extremities. You might hear that called edema, and it's usually treated with diuretics or vasodilators. Oftentimes you'll see a client is taking Lasix to help with the fluid in their extremities, usually their lower legs, sometimes in their hands. Clients who have end stage or ending stages of congestive heart failure will have frequent hospitalizations, inability to carry out physical activity without discomfort, and usually they become oxygen dependent, meaning they need supplemental oxygen in order to have any activity or comfort. End-stage renal disease, also called end-stage kidney disease. Your kidneys filter wastes and excess fluids from your blood, which are then excreted in your urine. When your kidneys lose their filtering capabilities, dangerous levels of fluid, electrolytes, and wastes can build up in your body. With end-stage renal disease, you need dialysis or a kidney transplant to stay alive. But you may also choose to forgo dialysis or transplant and opt for conservative care to manage your symptoms, aiming for the best quality of life possible during your remaining time. Clients with end-stage kidney disease often suffer from severe fluid buildup in the abdomen and extremities. You can sometimes hear those called ascites. Dialysis or transplant might be appropriate, but if the client does not want those things, it's time for hospice. Someone who has end-stage kidney disease who is not getting dialysis will have toxicities building up in their body, which can cause an altered mental status, confusion, and they might not act like their normal selves. Lung disease refers to any disease or disorder in which the lungs do not function properly. Lung disease is the third leading killer in the United States, responsible for 1 in 7 deaths, and is the leading cause of death among infants under the age of 1. Some lung disease, like asthma and emphysema, involving narrowing or blockage of the airways, resulting in poor airflow. Others, including pulmonary fibrosis, pneumonia, and lung cancer, are caused by a loss of elasticity in the lungs that produce a decrease in the total volume of air that the lungs are able to hold. Chronic obstructive pulmonary disease, also known as COPD, is an umbrella term used to describe progressive lung diseases, including emphysema, chronic bronchitis, refractory non-reversible asthma, and some forms of bronchiectasis. This disease is characterized by increasing breathlessness. With COPD, your lungs do not work as well as they once did, and you find it more difficult to breathe. As the disease progresses, your symptoms tend to get worse and more damage occurs in the lungs. This damage is permanent. Clients who have COPD and lung disease often have poor control of their symptoms. They can have disabling shortness of breath and discomfort. They may become oxygen dependent with supplemental oxygen and have oxygen-dependent hypoxemia at rest on room air, meaning that if they don't have their supplemental oxygen on, their oxygen levels drop. You will see that with a oximetry pulse ox. It will say often, like my go-to number was anything under 87% or really under 88% wasn't good. So if I saw someone's oxygen under 88% and they were having discomfort, that's when we talked about, do they need supplemental oxygen? Do we need to make med changes? That's not sustainable for life. Clients who have lung disease and COPD in their final stages will often have frequent hospitalizations because of attacks or episodes where they can't breathe and they panic and families panic and they get sent to the hospital. The problem is the damage is done and there's not much that can be done at those points. They will be put on steroids, there might be increase in breathing treatments, but those are all temporary fixes. Because of the amount of energy it takes for these clients to just breathe, let alone have any activity, it is very hard for them to take in enough calories to maintain their weight, and they will often have weight loss. Blood is carried to the brain via a complex network of arteries and vessels. A stroke occurs when one of these arteries becomes blocked or ruptured. A stroke is a sudden interruption in the blood supply of the brain. Most strokes are caused by an abrupt blockage of arteries leading to the brain, which is called an ischemic stroke. Other, hemorrhagic stroke. Because stroke occurs rapidly and requires immediate treatment, stroke is also called a brain attack. When the symptoms of a stroke last only a short time, less than an hour, this is called a TIA or a mini stroke. The effects of a stroke depend on which part of the brain is injured and how severely it is injured. Strokes may cause sudden weakness, loss of sensation, or difficulty with speaking, seeing, or walking. Since different parts of the brain control different areas and functions, it is usually the area immediately surrounding the stroke that is affected. Sometimes people with stroke have a headache, but stroke can also be completely painless. Some of the effects after a stroke can be the loss of ability to swallow, which will then result in weight loss. Sometimes these clients become chair or bed dependent, which decreases their functional ability. Some will suffer coma or persistent vegetative state due to irreversible damage. And oftentimes they will need help with all of their activities of daily living. If you have a client who has a history of stroke, who might be having weight loss, they're needing help with all of their activities of daily living, including feeding, it might be appropriate for the family to look into hospice services. DME, or durable medical equipment, is provided to the client by the hospice agency. The hospice agency pays for the equipment and is reimbursed with their Medicare benefit. Common equipment used in the home include a Hoyer lift and sling, a sit-stand lift and sling, nebulizer machines, BiPAPs, CPAPs, trilogies, oxygen concentrators, tilt and space wheelchairs, pivot discs, lift chairs, low air loss mattresses, and fall mats. If you're working with a client who's on hospice services and you feel that they could benefit from a certain type of durable medical equipment, do not hesitate to reach out to the hospice team and ask if they will provide that equipment. Hospice companies want their clients to have whatever they need to provide quality of life. And if that means a more comfortable cushion for a wheelchair, an oxygen concentrator, or a more comfortable bed, they will provide what they need to have better quality of life for their client. Often people show these signs before they are transitioning. The sooner someone is admitted to hospice, the better their experience will be. This helps hospice teams build a rapport with the family and the client, get to know them on a personal level, build trust, and meet their needs more effectively throughout their progression. When we work with clients in home care, it is common for us to be with them throughout their decline. Typically, the reason we were brought in to be home caregivers for the client is because they were having some type of decline. It is our duty as caregivers, as professional caregivers in the home, to be the eyes and ears for physicians, for families, and for the clients themselves who might not be able to advocate for what they need. If you have a client who is suffering from weight loss, frequent falls, decline in function where you're needing to help them with more things, they're getting frequent UTIs or frequent pneumonia, frequent hospitalizations or ER visits. They're not wanting to take their medications anymore. They're not wanting to do curative treatment. They're staying in bed more. They might be refusing to eat or drink. They might have aspiration pneumonia. Maybe they're on oxygen more than they used to be because that oxygen saturation's staying at 88% or lower if they're not on oxygen. These are all identifying factors that tell you, these should be red flags to you that say it is time to see if they qualify for hospice services. Now, of course, as professional caregivers, that is not our job to decide that, but it is our job to educate and advocate. It is not doing any harm to anyone to make observations, communicate those to the client, the family, the power of attorney, let them know what you're seeing, let them know why hospice might be helpful to them. And then it is up to the physician and the hospice agency to take it from there, to educate, to help that client get on services if they are needed. It can feel awkward to have this conversation, and sometimes it might be met with some difficulty or some hostility, and that's okay. But we have to do what's right for a client. We have to advocate for a client. If you bring this up with a family and they shut you down, that's okay. Let your supervisor know that you talked about it. Maybe it's something that they can bring up again in the future. But we never want someone to not take advantage of hospice services because they didn't know that they could qualify or they didn't know that they would benefit them. Okay, so you had the conversation with family. The client and the family are ready for hospice. Now what? Well, first, the client's physician needs to give an order for hospice. So assist the family or the client in making an appointment and speaking with the physician. Some physicians don't require an appointment to be made, especially if they've been following the client closely. Maybe they already know that the client was appropriate for hospice. So a referral will be made to a hospice admissions coordinator. It is the client and family's choice for what hospice company they want to use. It is no one else's choice. A facility cannot determine what hospice the client will use. A caregiver or a home care company cannot determine what hospice a client will use. It is up to the family and the client. If there is a company that you've had a good experience with, it's okay to share that, but it is not our choice, and we must be supportive regardless of what company or whether the client or family might choose that they don't want hospice at all. That's still their choice. After a referral is made to the admissions coordinator, the family will often schedule a meeting or an informational with the nurse or a social worker, maybe an admissions person at the hospice agency, and they'll ask their questions, they'll get their questions answered, they'll learn about what services can be provided. A hospice nurse then evaluates for appropriateness for hospice. This might sound a little silly because a doctor already said that they qualify. Well, the doctor is saying it's okay to evaluate. That's what that order is. The doctor says it's okay for the nurse to evaluate for hospice. Then the hospice nurse goes out, evaluates, and says, yes, they qualify, or no, they don't. The client or POA then signs consents. A hospice nurse will admit that client, It's not uncommon for the client to be admitted the same day, depending on staffing. We are in a global staffing crisis, so it might be later if it's not a critical admission. Follow-up visits are made within 24 hours by the hospice nurse and the bath aide in most cases, and all other disciplines must see the client within 5 days of admission. There are many types of pain and factors that affect how a person responds to pain. If you're not a nurse or a physician, it might not be really important for you to know all the different kinds of pain, but what is important is to know that pain is whatever the client says it is. We are not the pain police. We are not here to determine if the patient's complaints of pain or discomfort are real. And it's also important to know that there's different types of pain, and one person's experience of pain might not be the same as another. And pain can be different. I made the mistake early on in my career of working with a client who every day said they were in pain. So one day when I went into her room and she said she was in pain, I said, well, you have your pain medicine. I'll get that for you. You get it every day. She's always in pain. So it didn't seem abnormal. I didn't think to ask if it was the same pain as every day, and it wasn't. She was having a different type of pain that would likely not be resolved by her current pain management routine. I did learn from that lesson, but it's an important one to know that just because a person complains of back pain every day, or they say, oh, it's the same as it always is, I'm always in pain. No one deserves to be in pain, and we should do what we can to get them as comfortable as possible within what the client wants done. Does this pain scale look familiar? Using a pain scale is a more accurate way to measure the effectiveness of a pain management plan. Now, there's likely not a nurse in this world who hasn't had someone say that they had 8 out of 10 pain or 9 out of 10 pain and they were laughing watching a comedy. That doesn't mean that it's not what it is. It is not our determination. We are not the pain police. But a scale can help, especially with clients who might not understand the number scale. Having those faces can be very helpful for them to see what is a 6. And maybe a 6 to them is not a 6 to us. This tool is often utilized in clients with advanced dementia to determine pain. This utilizes nonverbal signs and symptoms of pain. It is often not helpful to ask a client with advanced dementia if they have pain. Maybe they can't tell you. Maybe they can't express their pain in a way that you'll understand. So we look for symptoms. We look for nonverbal symptoms that they might be having pain. For clients who are nonverbal, this is another helpful tool to determine a client's pain scale. Pain is often undertreated. Over 90% of pain in hospice can be controlled. This means it is not normal to be in pain when you are dying. Almost all patients can have good control of pain. Pain treatment often starts low and goes slow, but keeps increasing until the patient's pain goals are met. Unrelieved pain is a major source of fear and anxiety, which causes emotional symptoms as well as the physical symptoms. Most clients admitting to hospice services will have an as-needed or PRN, morphine, and lorazepam ordered at admission. They are sent out at admission for a lot of companies so that the client has them when they need them. A typical starting dose of morphine is 5 milligrams every hour as needed, and lorazepam 0.5 milligrams every 1 hour as needed. Not all clients are the same, and in no way do I mean to say that every client should have the same orders for pain and anxiety medication. But it is helpful to know what a common starting point is, so that way if you have a client's family who is nervous about morphine and thinks that getting 5 milligrams is a lot, you can assure them that 5 milligrams of morphine is a very common starting dose, and that morphine doses can go up quite a bit if the pain is not being resolved. If morphine and lorazepam cannot be used due to allergies or intolerance, there are many other options, including Dilaudid, oxycodone, Haldol, and others. clients can receive PRN pain medication in addition to the scheduled pain medication. I have an example here. If a client received a scheduled dose of pain medication at 4 p.m. and their next scheduled dose is at 8 p.m., but the client is having breakthrough pain at 4:30, that means after the pain medication was given and it should be working, they're still having pain. They can have their PRN dose and still get their scheduled dose at 8 p.m. The use of fentanyl patches has become more common for clients who have chronic pain. The advantage of using a patch is it provides a steady distribution of the medication over time. There are not the highs and lows, the peaks and valleys that will be seen in meds that have an immediate release. Scheduled Tylenol, 1,000 milligrams 3 times a day, is a great starting point for mild pain. Holistic services or non-medicinal, non-pharmacological treatments like heat, ice packs, stretching, massage, rest, elevation. These are all things that don't require medication that can be utilized to help provide comfort. Clients at end of life are extremely unlikely to become addicted to their pain medication if the pain medication is needed. And I put this here in bold, morphine does not hasten death. The reason we think, or the reason a lot of our population thinks that morphine causes death is because morphine is the most popular medication used at end of life. We use morphine because it is tested, it is trusted, it is affordable, it is effective. That's why we use morphine. Correlation does not mean causation. Morphine is not killing the client, their disease is killing them. When a client is transitioning or active, it is common for a hospice nurse to give morphine and lorazepam together, as the two medications can be more effective when used together. Many clients, healthcare workers, and families have that misconception about morphine, that morphine causes death. Typical morphine dosing is 10 to 20 milligrams every 4 hours as needed. That's not enough to cause respiratory depression and death in a client who needs pain relief. If you have concerns about the medication your client is receiving, if your client got their first dose of medication and you think they are snowed or they are lethargic or that it's keeping them asleep or that it's too much, it is okay to question, but it is not okay for us to make the statement that the medication is making them, that the medication is snowing them or that the nurse is snowing them. That is not okay for us as caregivers to say. What we can do is express our concerns to the hospice team, the hospice nurse, and maybe the dose was too high. Maybe they can go down on the dose a little bit. But it is not our job to say that the medication is what's causing that, because it's not always the case. When a client is at end of life and they can't open their mouth, how do you give comfort meds? Well, there are two options here, and I've actually learned a bit more about this since I became certified in hospice and palliative care, so I'm going to add a little bit of a correction to this. Buccal, which is in the cheeks, is a great method. However, it does not all get absorbed. Studies have shown that buccal administration of medication, some of the medication will get absorbed, but not all of it. Sublingual is truly the best place to put the syringe under the tongue and administer the medication for maximum absorption. Now, if it's end of life and the client's teeth are clenched and you can't get them to open their mouth, but you can get it in their cheek, the family should do what they can. We take what we can get. If the physician has not already given an order to hold or stop the other meds, like Tylenol or vitamins, maybe ask the hospice nurse if it would be a good idea to stop those. If the order says that it is oral, PO, SL, sublingual, it means you can use any of those above methods to give the medication. If you have not been authorized to give medication, you do not give medication. but this is good information that you can help educate the family with. And here I have a lovely volunteer hospice nurse who is helping me demonstrate where the syringe can go, even if the client won't open their mouth or can't wake up. At the beginning of this presentation, I told you that this presentation is based on my experience and my education. And this one specifically, I want you to know this is what I've used in my time as a hospice nurse. It might not be universal, and that's okay. But for me, when I'm looking at a client who's on hospice and I'm seeing that they're not eating as much, they're less responsive, they're sleeping more, they're pocketing food, I think that they're transitioning and they will likely pass away in 7 to 10 days. Now, that's not a crystal ball. It's not like we pull out a calendar and say, okay, John, you have to pass away in 7 to 10 days now because Kayla says you're transitioning. That's not how it works. I've been wrong many times and I've been right many times. A client who I would say is active, meaning they're in the final stages of the dying process and death could occur in the next 72 hours, is unresponsive. Often they have that fish out of water breathing. There might be mottling, but I will say not all clients have mottling. So just because you don't see mottling doesn't mean that they're not dying. They might have increased gurgling or secretions. You might see changes in skin temperature or color and having that rattling breathing. Hospice nurses use signs and symptoms as well as some of that just gut feeling to know, and it's to give a best guess to prepare the family. We always say we don't have a crystal ball, but this is what we suspect is going to happen. It's always better, in my opinion, to prepare the family for the worst, and if they get more time with their family member, that's just an added benefit. If you are working with a client who is in their final hours of life, it is common for them to have apnea, which is a gap in breathing. They'll be breathing and then they stop. And then you think, was that their last breath? And then they breathe again. That is normal progression. As long as they're comfortable and they don't have those signs of discomfort, just be there with them. Just be there with the family. Just be there with the client. When a client stops breathing and doesn't start breathing again, call hospice. Hospice nurses are available 24/7 to do death visits. The on-call hospice nurse. The hospice nurse will handle notifying the physician, they'll call the coroner, the mortuary, and if the family's not there, you can call the hospice nurse and they will let the family know. If the client's uncomfortable or if you have questions, call hospice. Hospice is available 24 hours a day, 7 days a week. They will do whatever they can over the phone to walk you through what needs to be done, and if that is not a solution, they will make a visit. About a month ago, I surveyed about 20 nurses, hospice nurses from all different agencies in the Omaha area and asked them what hospice nurses want caregivers to know or what they want them to do with their clients. I broke them down into 3 main categories. The first, personal cares. Keep doing oral cares. And I always told family members, if it feels awkward and it feels like you don't know what you should do oral cares. If you feel like you need to do something but there's nothing to do and you just want to help, do oral cares. Keep them clean and tidy. Continue to offer food and drink at meal times if the client's alert, but don't try to feed a client that is unresponsive or lethargic because they could choke and have aspiration pneumonia. One nurse had mentioned this number 4 here, and I completely agree. I would not have thought of it, but wash their hands so family members can hold their clean hands. When someone's been laying in bed in that process of dying, they can often be, their hands can get kind of clamped up and it might be sweaty and smelly, so wash their hands so that when a family member goes to hold the client's hand, it's clean. The second category is compassion. Show compassion for the family just as you would your own family. Understand that it's not personal if there's a mood swing or if they snip at you or if they're irritable. Those are normal parts of grieving. And be able to put your own opinions, fears, and feelings aside. We don't have to agree with hospice. We don't have to agree with the family or client's choices, but we have to follow the client's wishes and the plan of care. If a family member asks you to do something and they want it done a certain way, do it that way. It doesn't matter if you haven't seen this daughter in the 9 years you've been taking care of this client. They might be feeling a loss of control, and this could be a small way for them to get a little bit of control back. Don't treat all clients the same. Be flexible and adapt to the client's unique needs. Try not to judge the client and family. We don't know all the details of a relationship. Even if a client has told us some of the details of the relationship with their children or grandchildren or other family members, that's just one side of it. So we treat everyone with respect, even if it's a family member that you think doesn't care. The third category was communication. Keep talking to the client all the way until their last breath. And I added, and even after. One of the most beautiful experiences I had as a hospice nurse was working with a CNA who kept talking to the client even after the client was gone. She continued to tell the client what she was doing as we were giving the client their last bed bath. It was a level of love and respect that I had not ever seen. And ever since then, I realized how important it is not only for the family, but everyone in the room to know that you respect that client so much that you're going to continue to speak to them even after they're not there. Tell the client what you're doing as you're doing it, even if they're unresponsive. Keep talking to them as if they're alert and oriented. I often told family members that hearing was one of the last senses to go, and you should continue to tell stories, continue to talk to them, continue to tell them you love them. Even if they can't answer, they can still hear you. Know the signs of terminal restlessness and imminence, meaning the client is going to pass away imminently, and communicate them to the hospice team immediately. Communicate changes to the nurse, especially if you think the care plan needs updates or changes. Don't assume someone else will tell them, and that's something I ran into a lot as a hospice nurse, especially in facilities. I would have a caregiver, I'd go and see a client and a caregiver would say, oh, they've been like that for days. Well, no one had notified hospice, and everyone thought that another person would. So even if you think someone probably already told hospice, it would be better for you to communicate it and them hear it for a second time than them to not know at all. Be respectful in regards to time. If you say you're going to be there at a certain time, be there at a certain time. If you're running late, communicate. And finally, keep a journal or whiteboard with notes. A lot of programs, like the program we use, is called Access Care. It has an online portal where care notes are shared with family members. That's a great way for family members who don't live in the same vicinity to still have information and to be communicated with in an efficient and effective way that still is in a private and secure manner. I know I have said this about 17 times, but if your client is on hospice and you see a change in condition, call hospice. And if you don't have their phone number, call your manager right now and find out what the hospice phone number is, or Google it, put it in your phone, because if you're nervous, if you're anxious, and you need to be able to get a hold of them, you want to have it readily available. Thank you for taking the time to educate yourself on hospice and end-of-life care. It's not the most fun or glamorous topic in the world, but it is one that I care about deeply. If you have questions or concerns about anything that I said in this presentation today, I would invite you to either comment, tag me, comment, or you can email me at Kayla, that's K-A-Y-L-A, at truenorthhomecare.com. Even if you're not an employee, or you're not a client, or you're not a client's family, it doesn't matter. I am a free resource for information anytime you need. If you ever have questions or concerns when you're working with a client and you want a nurse's opinion, a non-biased nurse who is currently working as a hospice nurse, I would love to give you my opinion or maybe lead you in the direction of who you should call. At the end of the day, it is important for you to know how vital you are in the final days of a client's life. You might be the last person who talks to them. You might be the last bath they get. You might be the last person who fed them. That's important, and you shouldn't be taken for granted. Thank you for what you do. We couldn't provide the care that clients in hospice need if it wasn't for caregivers like yourself.